This conference will now be recorded.
సో వినపడుతున్నారు ఇలా వాళ్ళు ఎవరు మాట్లాడతారా జ్యోతి ప్రకాష్ వినిపిస్తుందా?
Yes, sir. వినిపిస్తుంది.
Okay. Good morning to everyone. Today's topic about discussing is hematemesis. So these are some definitions. So hematemesis means we all know that vomitus of red blood or coffee ground material is called as hematemesis. Melena is dark, tarry, foul-smelling stool. And hematochezia means the bright red and frank blood through rectum. So occult GI bleed means there is no frank blood in a stool, but when we examine microscopically, we can found RBCs and there may be iron deficiency anemia. So occult blood means there is no frank blood, but we can found RBCs under microscope. So this is called occult GI bleed. So anatomy. When we call upper GI bleed means, so there is a part called ligament of teeth which separates the sigmoid colon through transverse colon. So this ligament of teeth from above the ligament of teeth is called as upper GI bleed. So most of the 70% of GI bleed occurs from above the ligament of teeth. Bleeding from the GIT distal to the ligament of teeth is called lower GI bleed. 30% of the GI bleeds related to this lower GI bleeding. So above the ligament of teeth, upper GI bleed. Below the ligament of teeth, lower GI bleed. So this is the anatomy. So we can find the ligament of teeth here. So this is the exposed part of ligament of teeth. So differentiation between upper GI bleed and lower GI bleed. So upper GI bleed means it occurs above the ligament of teeth. Lower GI bleed below the ligament of teeth. The presentation: upper GI bleed mostly present as hematemesis and melena, and lower GI bleed present with the hematochezia. When we do nasogastric aspiration, so we can find blood in upper GI bleed, whereas in lower GI bleed there is only clear fluid. When we do nasogastric aspiration, we can find blood in upper GI bleed and clear fluid in lower GI bleed. So blood urea nitrogen and creatinine ratio increased in upper GI bleed is almost greater than 25% to 25:1, whereas in lower GI bleed it is lower than 25:1. So blood sounds, bowel sounds are hyperactive in upper GI bleed, normal in lower GI bleed. These are some differentiating features about upper GI and lower GI bleeding. So upper GI bleeding, there are two types in upper GI bleed. One is variceal bleed, another one is non-variceal bleed. Variceal bleeds are accounts for 20% of upper GI bleed, whereas non-variceal bleeds are accounts for 80% of upper GI bleed. So causes of hematemesis. So these are some spurious causes of hematemesis. So when we swallow blood, so when will we swallow means when there is hemoptysis. So blood in a sputum. When we swallow the blood with the sputum, so it can present as hematemesis. Whereas bleeding from nose, throat, and mouth mimic as hematemesis. These are the spurious causes of hematemesis. One is hemoptysis and bleed from nose, throat, and mouth. Disease of the esophagus. These are all causes for GI bleedings. These are upper GI bleeding causes. Disease of the esophagus. So reflux esophagitis and hiatus hernia may cause upper GI bleed. Blood loss in this is usually chronic and presenting as iron deficiency anemia. So reflux esophagitis and hiatus hernia, they may not present as frank blood, but they present as chronic GI bleed and may present with iron deficiency anemia. So esophageal varices, these are the causes for acute upper GI bleed. Esophageal varices means dilated veins in the distal esophagus, the upper stomach, and as a result of portal hypertension due to cirrhosis of the liver. They may cause profuse bleeding and when they ruptures. So Mallory-Weiss syndrome. So Mallory-Weiss syndrome means when there is a sudden cough or sudden vomiting with a bout. So there may be partial tear in mucosa of the lower end of the esophagus. So that will leads to bleeding of the bleeding through mouth. So that will leads to acute upper GI bleed. So these stops spontaneously in 80 to 90% of the cases. So one more condition is called as Borjev syndrome. This is also present with the upper GI bleed. Mallory-Weiss means there is no complete tear, but in Borjev syndrome, so we can find complete tear through mucosa and muscularis propria of the esophagus. So Borjev syndrome is somewhat dangerous. So, esophageal ulcers may be benign or malignant, and they may be associated with the hiatal hernia and reflux esophagitis. It is a relatively uncommon cause. So esophageal ulcers are uncommon. So mediastinal tumors may be present as uh, present with upper GI bleed. So mediastinal tumors penetrating into the esophagus and aorta, they will lead to bleed through mouth. The foreign body perforating esophagus also cause hematemesis. So this is the stomach. Peptic ulcer. Peptic ulcers are most common cause of upper GI bleed. So infections and irritation leads to disruption of the mucosal barrier and has direct inflammatory effect on gastric and duodenal mucosa. As ulcer burrows deeper into the mucosa, weakening and necrosis of the arterial wall. When there is an ulcer in duodenum and stomach, so they will perforate and they will erode into the uh, arterial stomach wall arteries, and that will leads to hematemesis. This leads to pseudoaneurysm development and weakened wall rupture and hemorrhage occurs. So this is the small classification, so which classifies the upper GI ulcers. This is called as Forest classification. So this is divided into 1A. 1A means there is a arterial jet. That means arterial spot will be present. Whereas in 1B there is only arterial ooze will be present. 2A means only visible vessel is present. 2B means other than clot is there, and 2C means flat pigmentation. 3 means clean base ulcer. So this is 1A, that means arterial jet. We can find the arterial jet here. This is 1B, only oozing is present. 2A means there is a visible vessel. This is a visible vessel. 2, we can find a clot here. 2B means other than clot. 2C means flat pigmentation. So there is only flat pigment, no bleeding. So class 3 means clean base ulcer. So when there is a hematemesis, we can find bright red blood color or coffee ground color appearance of the blood. So why there is a coffee ground color appearance of the blood means, so when there is a chronic bleed, gastric acid reflection from stomach can lyse the hemoglobin and form the hematin. So hematin will appear as coffee ground appearance. Severe bleeding may occur medium or large size vessel is eroded. So when there is medium or large vessel will erode, there will be severe bleeding will be there. So profuse hemorrhage may cause feeling of faintness or restlessness, syncope. So when there is a moderate to severe bleed, so that will leads to shock. So all ulcers must be biopsied to exclude the malignancy. So when we find the peptic ulcer or gastric ulcer or duodenal ulcer, we have to do biopsy, because the ulcer may be there may be malignancy with ulcer. So that's why we must do the biopsy. Hemorrhagic and erosive gastropathy. This is also one of the cause for hematemesis. So this is visualized by endoscopy. So endoscopically visualized subepithelial hemorrhages are called as erosive gastropathy. So when we see through endoscopy, there will be subepithelial hemorrhages. This is called as erosive gastropathy. Most important cause is NSAID use or alcohol abuse. NSAID use and alcohol abuse is the most common cause for erosive gastropathy. And some other causes include stress-related gastritis, in extremely sick patient, serious trauma, major surgery or burns. These are all the causes for erosive gastropathy. Major intracranial disease or stress due to any cause that will lead to erosive gastropathy. So this is the erosive gastropathy. So these are the subepithelial hemorrhages. So tumors, severe hematemesis is rare in carcinoma of the stomach. If narrowing at pyloric area is there, so there may be a coffee colored streak of the blood may be there, but frank blood is rare in tumors. Hastler-Renda-Weber syndrome. This is also caused for upper GI bleed. This is caused by focal dilatation of the post-capillary venules, which have excessive layers of smooth muscle devoid of elastin. So there is a lack of elastin in the smooth muscles. That's why there is a dilatation at the post capillary venules that will lead to rupture and maybe that that will lead to rupture and hematemesis and shock. Disease of the duodenal ulcers. So duodenal ulcers are also most common cause of upper GI bleed. These are caused by either Helicobacter pylori or NSAID use. Hematemesis occurs when duodenal ulcer erodes into blood vessel. Some of the blood regurgitating through the pylorus into the stomach and maybe vomited, and the rest passing down to the GIT that will lead to melena. So duodenal ulcer may present with hematemesis and melena. So because that means some of the blood may pass through the pylorus and enters into the stomach and manifest as a hematemesis, and rest of the blood will pass through the rest of the GIT and present as melena. There may be dyspeptic history with epigastric pain is present in duodenal ulcers. So duodenal tumors, these are very rare and mostly arising from the ampulla of the water. So gallstone ulcerating into the duodenum also leads to upper GI bleed. So drugs causing upper GI bleed include anticoagulant and antiplatelet therapy. When we use anticoagulants and antiplatelet therapy, uh, uh, they will lead to significant GI bleed and hemorrhage. NSAIDs are also the most common cause of duodenal and gastric ulcers, and that may further leads to hematemesis. So other causes include dulophy lesion. So dulophy lesion is very important. That dulophy lesion is aberrant submucosal artery. So this aberrant submucosal artery can erode in subtle trauma, food entering into the GIT that will leads to bleed. Dulophy lesion is the most common lesion that will miss through endoscopy. So we cannot find the dulophy lesion except we are expertise in endoscopy. So aortoduodenal fistula, portal hypertension, so hepatic cirrhosis, thrombocytopenia, and non-thrombocytopenic purpura. These are all the causes for upper GI bleed. So how will we approach the acute GI bleed? So while we managing the upper GI bleed or acute GI bleeding, so we have to uh, assess immediately and do resuscitation first, and then stabilize the hemodynamic status of the patient, identify the source of the bleed, and stopping the active bleed, and treat the underlying cause and prevent the bleeding related mortality and prevent the recurrent bleed. So immediate assessment and resuscitation, assess the area of breathing and circulation, monitor the vital signs like pulse, blood pressure, and respiratory rate and temperature, assess the magnitude of bleeding, and initiate appropriate monitoring, history and examination, and lab evaluation. So assessment of a bleed. So symptoms and volume of blood loss. When there is a 500 ml of blood loss is there is no systemic signs and signs except in elderly patient and anemic patient. Anemic patients manifest with the 500 ml loss of blood, whereas in young patient there will be no manifestations. 1000 ml of when there is a loss of 1000 ml, that is almost 20% of reduction of the blood volume. So they will manifest with tachycardia, orthostatic hypotension, syncope, and lightheadedness, nausea, and sweating. So when we lost 2000 ml of blood, that means 2 liters, there will be 40% reduction of blood volume. So that will lead to profound shock and death. So drop in urine output less than 0.5 ml per kg per hour indicates moderate to marked hypovolemia. That means less than 45, 0.5 ml of per kg per hour means there is a moderate to severe blood loss will be there. So early signs of cessation of bleeding and restoration of blood volume is there is a return of normal of heart rate. So when we are resuscitating the patient, so how we will know that the patient is going to better or not means, so the heart rate will improve. So decreasing in the tachycardia, heart rate will decrease in effective resuscitation. So tilt test. So this is the one of the bedside tests. So tilt the head of the patient. So when we ask the patient to lie down on the end of the couch and tilt the head of the patient up to 75%, at the angle of 75 towards the downwards, and about at the for 3 minutes. So changing the heart rate and dip in systolic blood pressure is noted. So if heart rate is increases less than 20 beats per minute and absence of lightheadedness and indicates that there will be compensated blood loss. So when we do this maneuver, uh, if the heart rate is less than 20 beats per minute uh, and lightheadedness is very low, so that means the blood loss is compensated. So when the heart rate is increasing, the heart rate is more than 30 beats and the symptoms is present, so that means there is a decompensated blood loss or volume loss will be there. So fluid resuscitation. So patient's fluid levels are maintained by giving crystalloids like normal saline or ringer lactate. If hypoalbuminemia is there, so we have to provide colloids. The central line should be placed for fast fluid resuscitation and perfusion of vital organs. Do not put of the patient is to be observed, placing the patient in trend bird position. So general medical management. So oxygen support and blood transfusion. Maintain hematocrit 30% in elderly patient, 20 to 25% in young patients, so 25 to 28% in portal hypertension patient. So for the better monitoring of the patient, hematocrit values are very important. So hematocrit should be maintained 30% in elderly, 20 to 25 in young patients, and 25 to 28% in portal hypertension patient. In symptomatic thrombocytopenia, that means less than 50,000, so consider platelet transfusion. So gastric aspiration. So coffee ground when we do gastric aspiration, there will be coffee ground material or blood clots. There may be flesh bleed will be present, or there will be clear fluid may be present. So presence of clear fluid does not exclude the upper GI bleed. Example in case of duodenal causes. So when we find clear fluid in gastric aspiration, so that does not indicate there is no upper GI bleed. So duodenal ulcers may present with clear fluid in gastric aspiration. So nasogastric lavage. So saline is used with or without H2O2 or prokaryotic like erythromycin or metoclopramide are used. So endoscopy. So endoscopy is effective within 24 to 48 hours of bleeding. So urgent within 12 hours of bleeding. It is both diagnostic and therapeutic. So endoscopic therapeutic techniques include injection primarily with dilute epinephrine or contact thermal therapy like monopolar or bipolar cautery, or non-contact thermal therapy like argon plasma coagulation. So mechanical techniques like endoclips or loop or band ligation in vessel bleeding. So these are the causes and risk of rebleeding. So risk of rebleeding is more in active arterial bleeding, and the next cause is non-bleeding visible vessel, and there is a least risk of rebleeding is present with a clean base ulcer. So that is only less than 5%. Whereas in active arterial bleeding, there is a risk of rebleeding is 55 to 90%. So this is not necessary. So management of peptic ulcer patient. So we have to use proton pump inhibitors in peptic ulcer patient. So these proton pump inhibitors will decrease the pH, that will leads to fibrinolysis. That will leads to decrease in the fibrinolysis. So when there is a clot with the bleeding vessel, there is no lysis when we use the PPIs. So PPIs decrease the pH and decrease the fibrinolysis of the clot formed on a bleeding vessel. So they are initially given as bolus infusion or bolus infusion of omeprazole or pantoprazole. So 8 mg followed by continuous infusion of 8 mg per hour. So So we can use proton pump inhibitors along with the endotherapy. So this is most of the time favorable therapy in case of rebleeding to reduce the mortality and morbidity. So approach to the variceal bleeding. So variceal bleeding suspected based on history, and we have to resuscitate the patient like ABC, aero breathing and circulation. Start vasopressin or attenuated infusion. So when we find the bleeding spot, we can use the vasopressin or attenuated. So these vasopressin and attenuated will constrict the bleeding vessel and reduce the bleeding. Variceal bleeding is when variceal bleed is confirmed. So on esophagogastroscopy, endoscopic band ligation is performed, or injection sclerotherapy will be done. Or bleeding, if the bleeding stop, uh, continue the medical management. There is no bleed. If there is a no stop bleeding is not stopped, so we can perform next procedure like endoscopic clips or some other definitive procedures. Vasoconstrictors. So we can use this vasoconstrictor as a to stop the bleed. Vasopressin 0.1 to 0.5 unit per minute for 4 to 12 hours up to 48 hours. So somatostatin 250 micrograms bolus followed by 250 micrograms per hour IV infusion. Octreotide 50 micrograms bolus followed by 50 micrograms per hour IV infusion for 5 days. So endoscopic balloon using uh, Fengsteken Blackmore tube or Minnesota tube, Linton Nicholas tube. Balloon is inflated for less than 24 hours and rebleeding is seen after deflation in 75% of the cases. So these are endoscopic ballooning therapy. So these are the tubes which are used for balloon therapy. Fengsteken Blackmore tube, Minnesota tube, Linton Nicholas tube. Balloon is inflated for 24 hours and deflate the tube and assess for the rebleeding. In 75% cases, the bleeding will stop after endoscopic balloon therapy. So these are the endoscopic sclerosants. So when we inject these sclerosants, these sclerosants will stop the bleed by sclerosing the visible vessel. So these are the sclerosants like sodium murate, ethanolamine, polydognol 3%, sodium tetradicyl sulfate. Sodium murate, ethanolamine, polydocanol, and sodium tetradicyl sulfate. So these are the hematocrit values in upper GI bleeding. So follow up with the hematocrit value is very important while resuscitating the patient. So before bleeding, that is mostly 45%. Immediately after the bleed, hematocrit value is 45%. 24 to 70 hours after bleed, that is hematocrit value is 27%. When you resuscitate, we have to monitor the hematocrit value. So that should be normal level before the bleeding. So recurrent GI bleeding. So when there is a recurrent GI bleed, follow the endoscopic therapy. If there is an uh, initial control, mostly 80 to 95% will leads to will further progress to permanent control. If there is a rebleeding, so again perform the endoscopic therapy with alternative methods. If there is a 50% chance of permanent control, if there is a rebleed, go for surgery or angiography. Thank you.